very happy to be here in Greece. It's my second time here. I attended the meeting in 2004 or 5 in Creta, organized by Professor Helen Askitopoulou. She is also involved actively in this Congress, and I wish a very big success for this Congress. I'm sure the Congress will be successful.
Since yesterday, the 6th Mediterranean Conference in Emergency Medicine has been started. It has been co-organized by the European Society of Emergency Medicine, from the American Academy for Emergency Medicine, and from the Hellenic Society for Emergency Medicine.
We're really excited to be here. It's a beautiful location, and this is our biggest Mediterranean conference yet. This is the 6th one we've had. And we're very proud to be able to look back and see the growth of emergency medicine as a specialty in Europe. And we like to think that these conferences have played a role in that.
We have delegates from almost 50 different countries of the world.
The situation for emergency medicine in the United States is that we continue to grow. 20 years ago, there were a limited number of training opportunities for students who were completing medical school, but over time the number of training opportunities has increased, and as a result the number of formally trained and board-certified physicians working in emergency departments has gone up, and they have kind of pushed out those doctors who do not have formal training.
Emergency medicine is not a specialty now, and USEM, Society for Emergency Medicine, has a policy to develop and to implement emergency medicine as a primary specialty in all EU countries.
The biggest problem in our country is that it has not been recognized either from the Ministry of Health or the medical community and medical societies that emergency department, especially the emergency department that receive all of this large amount of people every day, talk about 5 to 6 million people per year. It has been much, much better to be run, the emergency department, by a core team of doctors that are training especially in emergency medicine than the multidisciplinary approach that is followed now. This is the biggest problem in Greece.
These are battles that we fought in the United States years ago, and it's not an issue anymore, but it has to be settled out in each individual country. And so one of my goals is for conferences like this to give established emergency physicians the necessary tools and information to take back to their hospitals or their governments and say, you know, emergency physicians can do this safely and effectively and take care of patients.
My experience in our department, although we are 6 people running a department that receives more than 500 patients per day, 500 to 600, and if we compare it with the number of doctors that are running the similar department in other countries, their number is more than 15 to 20. Although, in spite of this small number of doctors, this is extremely much better work that is being done there.
This goal will be achieved if we succeed to convince the Union of Medical Specialists in Europe. You know, this is a body in Brussels that give the authorization to have the medicine as a specialty inside the list of the UMS.
Some European countries are following the same path that has happened in the United States, with more and more training opportunities and more formally trained physicians.
The role of society is to promote, to help, and to enhance the level of science in our society in all Europe. Without research, the society will not exist.
Unfortunately, with our high prevalence of HIV and TB, especially in co-infection, we need the diagnostic tool to expedite the diagnosis in order to get a better outcome for our patients, because if we start our treatment earlier, then the outcome is much better, and they have reduced mortality and morbidity. Where it takes the diagnostic test away from radiologists and put it in the hands of the emergency physicians or the clinicians. So in patients who has positive TB, been diagnosed as HIV, plus that had a smear for TB sputum, and that is negative, that's specifically aimed, according to WHO guidelines, at these group of patients because they're expensive to actually diagnose. And then if you use FASH together with clinical acumen, together with other tests, imaging tests, together with a chest x-ray or with a culture, you can actually expedite the diagnosis. So you look at 7 specific views that you look at, and if you find extrapulmonary TB in any of them, for these specific cohort of patients, you can actually start TB treatment. After one course, novices or junior doctors could be at the level of 80% accuracy in comparison to experts. There's a certain amount of scans you need to do to reach adequate competency. In developing world system, usually a portable ultrasound can be picked up for, I need to think in euros now, between 20,000 euros to about 50,000 euros. But if you need to think what else do you need if you don't buy this, it's actually very cheap.
Our usual and standard approach to a patient who has a suspected subarachnoid hemorrhage is to do a CAT scan. If the CAT scan is negative, to do an LP. So there are really 2 questions. Can the CT angiogram change the paradigm of our workup for this severe headache by eliminating perhaps the lumbar puncture? And the second question is, if we have a negative workup, will a CT angiogram further elucidate otherwise missed disease? There is good evidence there as to how CT angiogram may or may not be helpful. Generally, an emergency physician can be comfortable if a patient has a negative plain CAT scan and a negative lumbar puncture that they do not have a subarachnoid hemorrhage. However, if you have a patient who has a somewhat atypical presentation, or if you have a patient in which subarachnoid is not the only problem that you need to rule out, for instance, I used the example of a postpartum patient with a severe headache, that perhaps this is due to venous thrombus in the brain as opposed to arterial bleeding. Well, that patient would need further imaging, not necessarily a CT angiogram, but perhaps. And the point is that there is still room for our clinical judgment, and that needs to be brought to bear. Not to overuse a technology, for instance, the CT angiogram, where it's not indicated, or as a routine, but yet to know when the CT LP negative workup is not the end of the workup. Among the disadvantages to using a CT angiogram on a routine basis, in addition to expense, radiation, there's certainly the exposure to contrast medium. And the more you do this on a population-based basis, you are going to run into more problems with dye allergy and nephrotoxicity, et cetera. There is, of course, the time, resource, and money and radiation expense to these tests, which is why, unless there is evidence that it's going to be helpful, we wouldn't want to recommend its use. There's also the issue of incidental findings of aneurysms. I did bring forth a new article for the past several months in the British Medical Journal, in which they did have exceedingly good results in ruling out subarachnoid hemorrhage with CAT scan only, modern-day CAT scanners, and overreads by neuroradiologists, with the extreme caveat that all of these scans were done within 6 hours of the onset of pain. If this proves to be true in further studies, this may well change the paradigm by which we, at least for those patients who present early, evaluate them for subarachnoid hemorrhage.
Often we've relied on the stethoscope and things like chest x-rays, and at times they have very poor accuracy. You won't totally change your management plan on basis of a stethoscope, or sometimes even a chest x-ray, because a chest x-ray in a sick patient may be inadequate, may be a poor expiratory film. Really, using ultrasound, we can just add another dimension of information in there. Certainly patients such as a trauma patient who may come in with an anterior pneumothorax, these people traditionally have had their pneumothorax missed on initial supine film. And if you're going to intubate them, then it's quite good to know there is a small pneumothorax, even though you may choose to do nothing about it. The same thing is with the breathless patient who comes in with COPD and a history of ischemic heart disease. Often they will have crackles and wheezes all over the chest. And to try and get an idea of the priorities, is this a COPD problem with maybe secondary to infection, or is it a primary failure problem due to cardiogenic problem, pathology? And that way, using ultrasound to help direct you towards the most appropriate initial treatment plan is excellent. This is one of the easiest things to learn with ultrasound. There's a few key principles you need to adhere to, but looking for pleural sliding, comet tail artifacts, also the seashore sign on M mode is a clear indicator that you've got a normal opposition between the visceral and parietal pleura. If you see the lung point, then you know it's only going to be a pneumothorax. On the whole, I think one of the most reassuring things is to see pleural sliding, and you will not see pleural sliding in a pneumothorax. Pleural sliding you can always compare to the other side, so that's one of the beauties about lung ultrasound. You've always got both sides to compare to. The learning curve depends on what you're doing. I think the quality of your mentorship is one of the most important things. If you guide a trainee through a quality training program, they will pick it up far easier. But there is a learning curve for myself because this is an area that not many of my colleagues do. So I'm probably the only person who does lung ultrasound in my hospital. And from that point of view, a lot of my experience has been self-taught. Often lung ultrasound will be just a part of an overall package of using ultrasound to help evaluate your patient. If you have a short of breath patient who comes in who's hypertensive, for instance, you can look at lung ultrasound, you can look at the heart, we'll look at the abdomen, look for DVT in the leg. So I use it to, everywhere where I have a question to ask, I will use the ultrasound machine.
Today, the internet and technology have made great strides. Today, you don't have to have your doctor at your bedside. Your doctor can be far, far away. What do I mean? Take a look for yourselves.
Hello, how are you?
Oops, hi, how are you?
Very good.
Well, the operator of this machine can be sitting on the other side of the earth or right next to me.
Hello, how are you?
It's a remote presence endpoint. It's called the RP7, and it allows physicians to remotely assess patients in rural settings or in their own hospital. Like if they wanted to do patient rounds in ICU in the evenings, they wouldn't have to go into the hospital. They could do them from home or wherever.
Dear friends, this concludes the third episode of the 6th Mediterranean Emergency Medicine Congress in Kos, Greece. Tomorrow we will be traveling back home, so the next episode will air on Thursday, 5 p.m. Greenwich time. So please stay tuned and we'll see you soon. Bye.